I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to the IDD Health Matters podcast. My name is Richard Chapman, and I'm a university-based researcher that studies self-determination and mental health for individuals with intellectual disabilities. If you're confused and you're expecting Craig, that's not going to happen this episode because I've decided to take over this podcast. Fun fact, this podcast has had 150 episodes. However, Craig has never been interviewed. So we are going to interview Craig Escude today and talk to him about what he does in the field and his perspective. So, Dr. Escude, welcome to the IDD Health Matters podcast. Tell the audience a little bit about yourself.
Well, first, I want to thank you for suggesting this.
Yeah.
It's a little weird being on the other side of the table here, but it's a welcomed thing for me, and I appreciate you asking, or kind of insisting that we do this. So my name is Craig Escude, as you said. I'm a family physician. I kind of fell into this field of healthcare for people with intellectual and developmental disabilities in the late 90s. I started working right out of residency at a federally qualified health center, and then decided that just wasn't what I really felt called to do for the rest of my career. So I began working at a large state mental hospital called Mississippi State Hospital, just outside of Jackson, Mississippi, providing health care to people who were there receiving treatment for mental health conditions. And found out about this place across the highway that was called Hudspeth Regional Center. And it was a place for people with severe and profound levels of intellectual and developmental disabilities and chronic medical conditions and mental health conditions as well. And I heard that they could use some assistance, some clinical assistance. So I popped in the front door and said, "Hey, could you use a doctor?" And the director was, this doesn't happen every day. Yes. So he's like, absolutely. So I began working there, and it wasn't long where I realized two things. One, this is where I could see myself working for a while. I like this environment. And the other thing was, I have no idea how to provide good health care to people with IDD. Unfortunately, because most training programs, most health professional schools do not teach healthcare providers about how to provide good health care for people with IDD.
Could I pause you for
Certainly.
a second? And what I'm going to do is I'm going to ask you questions, and I'm going to just take you forward and stuff like that. So, where did you go to medical school?
Oh, we're going way back. So I went to Louisiana State University in New Orleans, their medical school. And my undergrad was at LSU as well, just to let you know.
Okay, great. And where did you do your residency?
So for residency, I moved to Mississippi and did my residency in family medicine at UMC, University Medical Center.
Okay, so when you were working at the federally qualified health center, did you have any exposure to people with IDD?
Crazy, but no.
Okay, so fast forward, you were in this state hospital, state institution. You're like a lot of us in the field, but you're just trying to figure out how best to support people. What was that like?
Well, I always had an interest in medical school and residency in working with people who might have different challenges, specifically in mental health. Still, even though I had that interest, I really didn't have much experience at all in working with people with intellectual and developmental disabilities. So I started working at the state mental hospital, and again, also there, I felt I like this field. I like what I'm doing. Now, granted, I'm not a psychiatrist. I wasn't doing mental health care, but I was providing the physical health care for people at this very large institution. But I liked working with those people. It felt very comfortable for me, and it felt like a place I wanted to be. Now, when I started working after that at the at Hudspeth Regional Center, that's when I realized, it took me 5 minutes to realize I am not sure how to best provide good health care for people with intellectual and developmental disabilities. That was quite humbling. It was a little bit scary because I felt like I was working with a group of people that I had no training in how to do.
So I'm going to pause you right there, and this is just my interviewing style. You said it, you felt like you had no training and you did not know what you did. Then how did you go, what did you do? How did you go about providing care, and how did your training as a family physician inform you of that?
Well, the specifics about training as a family physician is family physicians see people of all ages who have a huge variety of medical conditions. So I think that training as a family physician and looking at kind of the whole person, looking at the dynamics, the family dynamics that are sometimes involved, was helpful. But still, I didn't know what I didn't know. And I think this is a common feeling. We have clinicians that say, oh, I know what Down syndrome is. I know what cerebral palsy is. I can handle this. But when you really get into it, you realize, wait a second, there are different ways. People who don't use words to communicate, for instance, can't tell you their symptoms. So how am I supposed to figure out what's going on without any understanding of things like the more common medical conditions you see, the way that sometimes people who are having a particular problem present very differently in people with IDD. And how I learned those things was from the nurses who had been working at the ICF, the Intermediate Care Facility, for many, many years, who learned they learned those things when they were early in that field as well, because for so much of the time, and still it's this way to some degree, that you learn from other people who have been working in the field, but not from the medical school or the nursing school, because they're not teaching those things. So that was very valuable to me, and just all of the things that I learned from people who had been working in the field for a long time taught me a lot. So that's the training I really received.
I'm going to hone in on that because I have family members that are nurses, and one thing we don't talk about is the nurses in the field. They think doctors are everything, but it's really the nurses that know what they are doing.
Yeah.
So say more about that and say what you've learned from those professionals.
So
yeah.
You're right about what you just said about how people think, oh, the doctor's the top of the chain, and the nurses, oh, they don't really know what's going on. And that is absolutely not true. And not only is it not true, I think it causes problems. It causes delays in diagnoses and poorer health outcomes when we don't listen to people such as family members of someone with a disability, or the nurse who's been working in this field for 20 years. And the doctor might come in and say, look, I'm the doctor, you're the nurse, I'm going to do what I think is right. Or you hear even worse things. Things like, well, we don't really need to do this because this person doesn't have a good quality of life. Why should we worry about it? And I can prove that because I did a survey of about 175 nurses who worked in the intellectual and disability field, and I asked them to tell me stories about good experiences they've had with clinicians, with doctors and others, and some not so good stories. And the not so good stories outweighed the good stories 2-to-1, and I had them write narratives of what they experienced, and those are the things they said. Well, the doctor told me this person won't live very long, so we don't need to do all of these things. Or, like I said, you're the nurse, I'm the doctor, here's what we're gonna do. It was amazing to hear this type of interactions that people were having when the nurses really knew a lot more than a lot of the clinicians, but the clinicians didn't really put a lot of faith in it.
And nurses get to determine whether you sleep at night or whether you get to do your job.
There's some truth to that too.
And that's a joke. So, back in the early days, what did you learn about supporting people with intellectual disabilities?
Where shall I start? And how much time do we have?
I don't know. But back in the early days, and what I'm trying to do is take you from your early days to when you're much wiser
and older. You can say it.
And older, yeah.
So one of the first things that impressed me when I was early on in my working at the ICF was I had a very kind, patient nurse she was the director of nursing, and she came and she sat down in my office. It probably was 2 or 3 weeks into the job, and she said very, very kindly, she said, one of the things you probably don't recognize, or that you might not realize it happens as much as it does, but there are a lot of people who get very constipated in this field. And I'm like, even constipation is not something talked about, because most people who recognize they're constipated, there are laxatives they can take, there's better food, and they don't necessarily go to the doctor because they're constipated. Well, people with IDD, it's often not recognized how big of a problem constipation is. And when someone can't, again, express to you, I haven't had a bowel movement in 3 days, my stomach's really hurting, what you might see is someone becoming aggressive because they're experiencing pain. They don't know how to express it in a way that other people express it. And it's not something I really thought I'd be dealing with very much. So that was the biggest and earliest learning curve that I had. And I'm so thankful that the director of nursing was respectful, and she understood that most people are not trained, like she wasn't trained to do this, and she figured it out the hard way. So one thing I learned, I'm going to do it this way for those of you who've seen some of my webinars. One thing I've learned, and I usually say constipation's the number one problem in this field, is that little tidbit. And then I started to learn how big of a problem aspiration and aspiration pneumonia was. And then it's like, well, why is it such a big problem? Well, there are risk factors. People are often on medicines that dry their mouth. People may have swallowing difficulties or challenges with oral motor functioning, so they're not swallowing very well. And learning some of the reasons for that. Another thing I learned through experience is how many people with intellectual disabilities have seizures, and that they're often much more challenging and much more difficult to treat. Many times you can't resolve them completely. So things like that were the things that I kind of learned the hard way. I couldn't find books or resources. The internet wasn't quite what it is today as far as being able to search things. But I also say I don't think there was a lot of research being done for people with IDD earlier as well. And then I think one of the more profound lessons, it's not just the medical care aspect of it, but it's the humanity of, or just recognizing that every person is a person first. And you shouldn't look at people based on a particular diagnosis that they have. And people are people first. And if we don't see them as people, we're less likely going to provide good care because we don't think it's as valuable.
And we, by the way, I don't think we tell people where we are right now. We're in Chicago right now. We're at the American Association for Intellectual and Developmental Disability, and Vincent Chesney, the incoming president, at his keynote today, talked about providing dignity to persons with intellectual disability. And I think when we treat people with respect, when we treat them like humans,
it changes things just a little bit when we're respectful and, like you said, at least recognizing that people with IDD also have the same wants, the same desires, for their lives that everyone does. It might be expressed in a little bit of a different way. Quality of life, I always say this too, quality of life is something that the person should determine. It's how they enjoy their lives, even if it's a different quality of life than someone else might have. It's still a valuable quality of life to each person.
Yep. So you worked in Mississippi at this
Intermediate Care Facility, ICF.
for how many years?
21-ish, I would say.
21. Okay, and then what did you do after that?
Well, I'm going to answer that with a little backup right before I left, because it prompted me to do what I do now. Okay. So in the 2010-ish range, the Department of Justice came into the state, and the intermediate care facility where I worked was the closest one to the airport. So they always came and visited our place, and what they were saying is that we were too heavily weighted on institutional care for people with IDD and less heavily weighted on community-based supports and services. And to be honest, I had the same bias and prejudice that many people did, where I thought, wow, the people that are at our facility are so significantly affected by their intellectual and developmental disability. I don't understand how they could live more independently, because many of them had lots of chronic health conditions and very complex seizure disorders and so on and so forth. So I was like, I don't know how we can put some people in the community and expect them to have good outcomes. So I knew I had a lot to learn. So I created a program in the state of Mississippi, based on looking at other states that were more advanced in their supports of people with IDD in community-based settings. We went to other states so that I could see for myself how this can be done. And I was quite amazed seeing how many people, and some states have no facility-based programs. They're 100% community-based supports. So I realized, gosh, there are better ways to support people with IDD, even if they have a lot of needs. They don't necessarily have to be in an institution. So as we began to move people out into community services, though, and I knew this and learned this from the other states we visited, I began to have a lot of concern that now people who have been receiving what I truly think was excellent health care in a facility. They had nurses who had been there for years and know everything about them. They had doctors who learned either the hard way, or I don't think there's an easy way, but you learn how to provide good health care. So they have specialized clinicians around them all the time. And I knew that when people were going to move into a community settings, they were going to receive their health care from the community-based doctor or nurse practitioner or dentist or whatever it was. And again, based on my own lack of knowledge and understanding, I knew that the outcomes were not going to be good.
Yeah.
People were not going to do well because they're, again, going to be seen by a clinician who has no training in how to provide good health care. So I developed a program in the state to provide training and education and clinical consultations to nurses, to doctors, to really healthcare professionals in general, to know how to provide better health care for people with IDD. Part of that training, part of that experience that we built there was a series of core, I guess you could say, lectures that I started providing to medical students and in conferences for doctors and nurses and other healthcare providers. And a lot of clinicians were like, why do we need to learn this stuff? And I seriously had that. I'm like, why don't you let me tell you why, and it'll make sense. And as I began to tell the story more, people began to come up to me. Now, these are doctors who had been working for 20 years. And they're like, I had no idea that, all the things you talked about, the more chronic conditions that we see more often, the how big constipation is and all of that. And it opened their eyes to something that, again, I had to learn the hard way. During that process, I learned about a company. At that time, it was called Health Risk Screening. Now we're called IntellectAbility. But I learned about the company and I realized, again, I can't believe I worked in the field this long without knowing about this, but I learned that the company is focused on helping clinicians, supporters of any type, helping them to recognize health risks that are so often missed if you don't have training or understanding in this field. And not only that, the tool helps you recognize the risks, but it also provides actionable steps for supporters to take to improve those outcomes and reduce those risks. And I'm like, my gosh, this is an incredible tool. And then also learned that they also develop like training courses, e-learn courses to help clinicians understand things like what we call the Fatal Five, the top preventable causes of illness and death in people with IDD. And I'm like, wow, this is just dovetails perfectly with what I'm trying to do in the state, is help people learn how to provide better health care and recognize health risks in people with IDD. So after a few conversations with the CEO of the company, I began to get more and more excited, just saying, okay, this dovetails so perfectly with what I'm trying to do in the state. Yeah. And at the same time, the company was looking for someone to kind of do what I do, give talks, give lectures, build relationships. The founder of the company was a nurse named Karen Green McGowan, and she was getting up in age and couldn't do the traveling and all like she was. And so it just, I think it was a match made in heaven. The company was looking for someone that had the training and background experience that I had, and I could see myself taking all of this information that I had learned on my own and was beginning to provide it just in Mississippi. I was like, okay, now I can provide this information to a much wider audience. Yeah, sure. And I felt a little like, but I'm giving up practicing medicine and I don't really want to do that. But I came to realize that I'm still very much improving people's lives by providing others with the information that I learned the hard way.
So I have a question about that. Are you still licensed or board certified anywhere? And when was the last time you practiced?
So when I started with IntellectAbility, it was 2018, okay. And that's the last time I truly saw a patient, saw a person as a clinician. But I do maintain my license. I also am board certified by the American Academy of Family Physicians still, and am a fellow of the American Academy of Family Physicians. I also jumped on another very new and small board, the American Academy of Developmental Medicine.
Yeah.
I was the 7th physician in the whole country to be board certified from that board. And since we're here at AAIDD, I'm a fellow of AAIDD as well.
Yeah, yep. Great. Well, before we close, is there anything that you want to say?
Again, that's probably 3 or 4 episodes worth of material, but I think we have to impress, as a society, as clinicians, as people from this field, as family members who have people with IDD, we have to train healthcare providers in this field. I know for a fact health outcomes will improve. People's lives will improve. People will not be suffering from fixable and treatable conditions unknowingly and suffering needlessly from things that can be treated. So we have to advocate to ensure that training not only is provided, but that it becomes a mandated part of medical schools and nursing schools and OT and PT and dental schools and all of that, because it will save lives. It will keep people from suffering needlessly from treatable conditions, and help enable people with intellectual disabilities to live a life that they want to live, a life that they feel good about, a life that they love. Because none of us live a life that we love if we have constipation that's been untreated for a year, if we have dental abscesses that are causing a person constant pain because providers don't really know to look at, don't know how to look at certain health conditions like that other people take for granted. So I highly want everyone to advocate in any way they can to train healthcare providers better. So that's the biggest thing.
I'm Dr. Craig Escude, President of IntellectAbility. State developmental disability agencies, managed care organizations, and providers across the United States use IntellectAbility's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support.
Tell me about 3 things that can improve healthcare for persons with intellectual disabilities. Just 3 things.
All right. Number 1, what I just finished talking about, education, 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 education. So that we simply have to improve.
Okay.
The other thing is we do have to recognize that people are people first. People with IDD, they're not a diagnosis. Oh, this is an intellectually disabled person. This is a person who happens to have an intellectual disability. And that doesn't negate wanting to do things that you want to do in life in the way that you can. They may need more support or a different type of support, but when you really think about it, we all need support in our lives. We all do, and so it's just recognizing that this person might need a little more support in some ways or another, but we have to see people as worthy of being supported and having their health care needs met.
And I'm going to just say they're worthy because they're a person.
Because they're a human.
Okay, I mean that qualifies them.
Yeah.
One thing, Craig. Yeah.
So that was only 2, wasn't
Yes.
it? The third thing is, please don't underestimate how many problems someone being constipated can have. Because, boy, people die from that. aside from suffering chronically from that. So if you're in the healthcare field and someone has a new change in their behavior, there can be many causes, but we have to think about medical causes that are treatable and fixable first, such as constipation, because that's the number one thing you got to think about. There certainly could be a mental health condition. It certainly could be a communication issue. But please work hard to recognize that healthcare problems, many are treatable and fixable, and often are the cause of a change in a person's behavior. So think medical first.
Thank you.
Thank you. Appreciate it.
The IDD Health Matters podcast is a production of IntellectAbility. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.